Hi, my name is Dr. Carl. Here we're going to be talking about what I learnt at the 2026 Royal College of Paediatrics and Child Health Conference. We'll be looking at the latest updates in asthma, the latest data on cancer, the latest research projects, and lessons for major incident planning. If you'd like to subscribe or collaborate, do get in touch. Asthma remains one of the commonest chronic conditions we see, and poor control is associated with exacerbations, emergency department attendances, hospital admissions, and significant impacts on quality of life. Traditionally, children have been prescribed a regular preventer or brown inhaler alongside a separate reliever or blue inhaler to be used only when symptoms occur. However, time and time again, we see that adherence to preventer therapy is often poor. MART combines both functions into a single inhaler, delivering inhaled corticosteroid whenever a reliever dose is taken. This approach has been shown to reduce severe exacerbations in many patients and is increasingly reflected in national and international guidance. MART should be considered earlier in children with poorly controlled asthma who continue to require frequent reliever therapy or experience recurrent attacks. What about air? Traditionally, children with infrequent asthma symptoms have been managed with a short-acting beta agonist, such as salbutamol, used only when required. However, we now recognize that even patients with apparently mild asthma remain at severe risk of severe exacerbations, and that SABA alone does not address the underlying airway inflammation that typifies asthma. AIR, or anti-inflammatory reliever therapy, uses a combination inhaler containing both an inhaled corticosteroid and formoterol as the reliever medication. This means that whenever symptoms occur, anti-inflammatory treatment is delivered alongside bronchodilation. The result is a simpler treatment approach that may reduce exacerbation risk while avoiding the need for regular daily preventative therapy in selected patients. Now, I'll be talking about the latest updates in pediatric emergency medicine research. But for more about PARUCI and APEM, organizations leading the way on this, there is a conference in Southampton this September. Here we can see the top 10 priority areas for research in the UK, as agreed by the organisation PARUCI, Paediatric Emergency Research UK and Ireland. It's not a surprise to see mental health near the top. We can also see the likes of overcrowding, monitoring and triage, showing us that process matters. In addition, there are a number of ongoing studies. Belly POCUS is defining the normal ultrasound appearance of right iliac fossa lymph nodes in healthy children, with the aim of improving the diagnosis of mesenteric adenitis using point-of-care ultrasound. CRESCENT is testing whether adding 95% oxygen with 5% carbon dioxide as a gas mixture to the standard treatment for convulsive status epilepticus can more effectively terminate the seizure earlier and prevent the need for additional treatment. CURLY is determining the shortest effective course of oral cephalexin antibiotic for febrile urinary tract infections in infants and young children. AVITA is comparing intravenous magnesium, IV salbutamol and IV aminophylline to determine the most effective second-line treatment for children presenting with severe acute asthma in the emergency department. HOPSA has been looking at whether early high flow humidified oxygen in children with acute severe asthma reduces the need to escalate to intravenous bronchodilator therapy as compared to standard care. And BACB has been comparing different respiratory support strategies, i.e. high flow nasal cannula, humidified oxygen and CPAP, to identify which of those two represents the best treatment for infants hospitalized with moderate or severe bronchiolitis. Orthopedic research is also prevalent. Most notably, the CRAFT study has now reported its main results, published in The Lancet in 2026. The take-home messages: many severely displaced distal radius fractures in children aged 4 to 10 years do not require surgery. A well-molded cast alone is an appropriate first-line treatment for most patients. Surgery produced only a small early improvement in function, and the difference was below that which families considered meaningful. By 6 months, functional outcomes were essentially the same, whether children had surgery or casting alone. And of course, surgery carries more harms. Casting alone was cheaper, saving the NHS about £1,600 per child, and even completely off-ended fractures remodelled well in younger children, supporting confidence in their remarkable healing potential. So, for children aged 4 to 10 with severely displaced distal radius fractures, a cast-first approach achieves excellent long-term outcomes, avoiding unnecessary surgery, complication, and health costs. Upcoming research is shown here. Roots is looking at the use of intramuscular midazolam in the pre-hospital care of convulsive status epilepticus. Supraman is looking at the management of supracondylar fractures. Luna is looking at the use of intranasal ketamine for convulsive status epilepticus. Optic will be looking and comparing oral versus intravenous antibiotics for the treatment of preseptal cellulitis. STIC is comparing splinting versus casting for femoral fractures in children. And Sentinel study is trying to identify what injuries might represent a sentinel injury and a way of identifying child abuse cases earlier. Now we're going to take a look at the latest in childhood cancer. This year, the Childhood Cancer Diagnosis Study, an observational study looking at referral pathways and diagnostic intervals in children and young people with cancer, was published. This is important because we know that cancer remains the leading cause of death in children. The study found that diagnostic intervals varied by age and the type of cancer. Older children on average are waiting longer, more than 2 to 3 weeks. Certain tumours like bone tumours, melanomas, lymphomas, and CNS brain tumours are also taking longer to be diagnosed. Furthermore, when children are identified and ultimately diagnosed with cancer, and we look backwards, we can see that they often have more than 2 symptoms. 50% have 3 or less, and the mean number of symptoms is 4. So when there is a persistence of symptoms, a number of symptoms, that should raise alarm. Unfortunately, the symptoms themselves are often non-specific, but it is the number of them that might help us identify early cases. This slide shows us that picking up and identifying the early clues of cancer in children is very much the business of emergency departments. For all the cancers shown, the red represents the proportion that was first identified in the emergency setting. The outcome of all of this retrospective work looking at cancer pathways, cancer diagnosis, and cancer diagnostic intervals is the following initiative called Child Cancer Smart. It is in its infancy, and following in the footsteps of Head Smart, it is an evidence-based public and professional awareness campaign to improve the early diagnosis of cancer in children and teenagers aged 0 to 13 years. When you see a child, think, could it be cancer? Remember, if there are 3 persistent symptoms, there have been multiple attendances or 3 previous visits to healthcare, and these symptoms have persisted or remained unexplained for more than 3 weeks, pick up the phone and consider further investigation for possible cancer. We're going to look at major incident planning. July 17th, 2025. A school bus carrying 70 children overturned. A major incident was declared involving police, fire, ambulance, air transport, and the local hospital. Unfortunately, 1 child tragically died at the scene. However, many more children were transported to nearby health services. At the conference, the general paediatrician on call discussed and explained the various issues, challenges, and lessons that she took away from this terrible disaster so that we might learn how to better prepare. One important element was channels of communication. What happened on the day was that a number of teams, those in the emergency department, those in paediatrics, those in intensive care, those as part of the trauma network, were all seamlessly able to communicate with each other using WhatsApp. Another issue was the distribution of staff and how best to use the expertise. Rather than bringing paediatric staff down to the emergency department, many of whom would not have been trained in trauma, it was deemed better to have them work upstairs and move the current A&E caseload, the people waiting in children's A&E, up to the children's department, making space in A&E for the incoming casualties, and so putting to use the paediatric expertise with that group of children, in addition to looking at discharge, reverse discharge of children, and movement of children to other spaces, for example, babies to NICU, and children who were likely going to be discharged to the outpatient department. Kit was also challenging, and so kit was acquired from NICU, from the ward, and brought to A&E. Time, of course, was a big factor, and a lot happened quickly. On reflection, the paediatric team could have been involved earlier in the process, and certainly another takeaway was the idea that help should always be asked for as early as possible. Another notable challenge was how children were turning up without any identifying features. They were not able to give their name and age, and it was difficult to implement the IT and reception and booking in processes. When there's chaos and a lot of busy casualties, this made the ordering of investigations, the planning and transfer of patients elsewhere, and putting kids through scanners all the more difficult and time consuming. As I said earlier, there was unfortunately one tragic death. A decision was made early to separate the death process and death procedures for this child away and separate to the ongoing care of other children. This meant that not only was dignity maintained for that family and child, but the ongoing active resuscitation efforts and care for the casualties was not disrupted. Finally, when the event was stood down, it wasn't actually recognised that business had not returned to usual. The inpatient care had been totally disrupted. Whilst incoming casualties had ended, there were still issues getting services back to routine levels. So further takeaways were improving communication across the areas and departments at the start, but also at the end. This video represents lessons that I have learnt. It is not meant to replace your own interpretation of the latest updates in paediatric emergency medicine and care, but I hope it has been thought-provoking and interesting. Thanks for your time.